Yo, what is up, my Nakama? So my name is Daniel, and I'm a current third year medical student. And in this video, I wanted to share my thoughts and reflections of my past rotation that I just completed, which was my psychiatry rotation. So let's get started. Okay, so this video is going to be kind of like a chatting video. I don't have any script. I'm just going to go from the heart and how I felt genuinely and honestly about my psychiatry rotation. So my psychiatry rotation was my second rotation of my third year of medical school. My first one was neurology, and I have a video where I talked about it, and I'm going to link it somewhere here. But in this video, I'm going to discuss psychiatry. And I kind of want to do this for every rotation that I do, just as a kind of journal and as kind of a log for you guys that are interested in medical school or about to start your third year, to give you a kind of little intro or a little preview as to what you can expect from this rotation. And obviously each medical school is different, and some of us don't even have the same rotations, but for the most part, I think every medical school does neurology, surgery, internal medicine, family medicine, and psychiatry. So yeah, I just got finished with psychiatry, and overall, I have to say that I really enjoyed psychiatry a lot. At least in terms of our hours and our workload, it was pretty chill. If you got your work done by noon or 1, you had the rest of the afternoon to study. It depended on your attendings. So some attendings, they like to spend a lot of time with the patients, especially with psychiatry, because you are there to hear a patient's entire story, and you have to hear collateral. Collateral meaning information from like family members, siblings, children, anything like that. Psychiatry, it is a little more patient interaction. There's a lot more story involved compared to like you're in the ICU and you just like things are happening quick and you're just there kind of for medically related, acute medically related reasons. A lot of people with psychiatry are kind of long-term management of depression. There are acute psychiatric events like an acute manic episode or like a suicide attempt. But once they're in the hospital, like in the inpatient unit, you're kind of managing them for quite some time until you feel like they're ready to be discharged. But overall, I enjoyed my time in psychiatry. It was very interesting compared to anything else that I've done in medical school, because, everything else in medical school, it's kind of like, I guess just to give an example, like you're reviewing labs, you're reviewing imaging. A lot of it is kind of very black and white and somewhat strict in terms of like this cutoff or this lab value, or this patient that has like diabetic ketoacidosis because of these lab values and this glucose level and this potassium level and stuff like that. Things are a little bit more clear cut in other avenues of medicine. But with psychiatry, it's a lot more involved, I think, with the patient and your interactions with the patient, because you're trying to help someone at the end of the day kind of go through life to some extent. I mean, everyone probably has feelings of depression, or they might, hit some of the categories of depression. Because to be clinically diagnosed with depression, for example, there's like a mnemonic you can use called SIGI-CAPS. And that acronym stands for a bunch of different factors like anhedonia, depressed mood, disinterest in activities. And on a day-to-day basis, like a lot of us have those feelings, but we might not necessarily hit all of those categories to be actually clinically diagnosed with major depressive disorder. But that's kind of why it's really important to have a really good history with the patient so that you can understand where they're coming from, what their past medical history is, their social factors that are affecting their life. You need to really get to know the patient really well so that you can treat them hopefully in all avenues of their life. Because, they might stay in the hospital for 5 or 6 days, you change their medications, you give them some antidepressants, but if they go back home to like a similar environment that they were in when they came in, then they're just gonna kind of fall back into their regular ways. But so our psychiatry block, it was 4 weeks long, and we had 1 week of adult inpatient, then we had 1 week of child inpatient, then we had 1 week of outpatient and ED, and then our final week was consult week. So just to break down the weeks, the first week that was adult inpatient, It was basically adults that are admitted to the ED and then either voluntary or involuntarily get sent to the adult psychiatric unit. And there's a multitude of reasons why people get sent to the unit. Suicidal ideation is one of them. If you feel like as a physician that a patient is a harm to themselves or a harm to others, then that is kind of, you are required to admit them to the inpatient unit, either voluntarily, hopefully, or involuntarily if the patient doesn't agree so. There's also like substance abuse problems. If they have, really significant depression, if they have a very significant manic episode because of bipolar, for reasons like that, they might be admitted to the inpatient unit. And it was definitely super interesting to be in a psychiatric unit. It was totally different than a regular medical unit. It was a lot more open. Like patients, they're allowed to walk around. It's kind of like a open door policy. It's totally different than like a regular medical ward. So it was super interesting to be part of that environment and to be part of their care. And I mean, one thing that I felt like all the residents and attendings kind of displayed was that they really cared for all their patients and they really wanted them to all get better. They weren't like facetious in any way. They were actually very empathetic to the struggles of all of our patients, and it was really nice to see that interaction. So I definitely took that to heart when I saw those interactions that my residents had with our patients. The second week was our child inpatient week, so still in the hospital, but now with children. And it could be for the same reason. It could be like suicidal ideations, some sort of trauma or PTSD, a whole multitude of reasons. And I do have to admit that some of these cases that we saw are like difficult to talk about, especially with the children. And it is difficult to not take things that you see in the hospital home. And I mean, some of these children that were in the psychiatric hospital, they're in for awful reasons. And I'm not going to go too into detail about why they were in there, but you can kind of imagine what some children's living situations are and some of the things that they go through. And it was nice being part of their care team and trying to help them as much as we can in the hospital. But one frustrating thing for me at least was, it is a 5 or 7 day hospital stay. And at the end of the day, you're still going to send the child back to their home environment that may have caused or exacerbated whatever psychiatric condition they came into the hospital with. So, I mean, the best we can do, at least in the inpatient setting, is, treat the child there, establish some coping mechanisms, kind of teach them about, if they're diagnosed with some sort of psychiatric disorder, just teach them about it so that they're familiar with it and they know how to handle it. And I think one of the most important things that we do is we have family meetings. So it's the child plus the mother or the guardian and father or whoever's in their family. It's like a collaborative meeting where we discuss, what we're going to do moving forward and the plan of action we have to kind of treat this child's psychiatric condition. And that's one of the most important times because a lot of times there's like a lot of tension going on between family members and, the kids, they don't, as a child, you don't want to be locked up in a hospital really. It's not like the greatest of settings to learn new things, but you do the best you can and you try and make those family meetings as meaningful as possible. And hopefully when the children are discharged from the hospital, they've learned new coping mechanisms and they've, got some medicines that can hopefully help them as well if they need any medications. But yeah, I would say it was a little bit difficult, like seeing some of the situations the children were in and then just like going back home completely normal. Like you honestly can't go back home normal, but at some point you do kind of have to cut off like your workplace environment with your home environment. And I can see how that can be difficult to do as a child psychiatrist. So I totally appreciate the work that child psychiatrists do. They are fantastic people. And we really need as many psychiatrists as we can get, especially moving forward. So many things I saw were directly related to social isolation and the pandemic and virtual school, there's so many cases that like were related to those facts about social isolation, and it's kind of difficult to balance now, you know, like, do you send kids back to school, but then you risk more spread of the virus? So it's definitely a tough situation to be as like a 13, 14-year-old, I can imagine. But I appreciate all the work that child psychiatrists do at the end of the day. So my third week, it was our ED week. So a little bit more fast-paced, and we're seeing patients in the emergency department as they present. And that was definitely real interesting to see, because when we saw patients in the inpatient unit, we're kind of monitoring them over a long time. And usually by that point, they've calmed down. They received their ED medications. Like if they're in a manic episode, they received Ativan and maybe haloperidol, some antipsychotics. So they're kind of already stabilized. But when we get consulted in the ED, that's like when the patient is manic or when they're expressing suicidal thoughts. So it's definitely a way more acute environment to be in terms of psychiatry. And it was definitely super interesting because, like, I mean, the way you interact with patients is completely different in the ED when someone's in a manic episode. Sometimes you have to be a little bit more loud. You have to like interrupt patients, you know, if they're just talking and being extremely loud. A lot of the times, you know, you are thinking about your safety. If someone's really aggressive or overdosed on a certain medication that causes them to be more aggressive, then you do have to think about, you know, your position in the room, you know, because if a patient decides to attack you or assault you, you got to be ready to kind of leave the room and have the police officer nearby. But, you know, I never felt unsafe during my psychiatry rotation. And there was always like security personnel staffed in the event that something were to happen. But, you know, I did have to deal with like manic patients and people who like overdosed and people who had like alcohol intoxication. So it's definitely interesting to be in that environment. It was definitely very different compared to the inpatient weeks. And then finally, our last week was the psych consult week. And I enjoyed this week a lot, partly because it was our shelf week. So we kind of got out a little bit early, usually on most days. And also we only had like 3 consults for the entire week, which is crazy. And like we consult basically for the whole hospital. So what this means is that like if someone is in the cardiology unit and then develops some sort of psychosis or suicidal ideation, then psychiatry will be consulted, even though they're like in a different unit of the hospital. And there was only like 3 consults really that we had. So that was definitely pretty interesting. And by that point in time, I felt really confident in like my mental status exam. The mental status exam is basically the physical exam for psychiatry. And with this exam, basically, we're observing everything that we see in the patient the moment we see them. We observe how they talk, their speech cadence, what they look like, whether their hair is disheveled, what their teeth, what their eyes look like, whether they're maintaining eye contact. We discuss their thought process, whether it's like tangential or circumferential. We discuss like their mood, their affect. It's basically their entire kind of mental status and somewhat of their physical status as well. Like if they have any psychomotor agitation, anything like that. And this is kind of what the comprehensive physical exam is, except in terms of psychiatry. So I got really good at doing the mental status exam by week 4. And kind of one thing I feel like with all these rotations is that by the time you feel super confident in like diagnosing people and writing notes and doing like the specific physical exams or mental status exams for the rotation you're on, the rotation is just over. So you have no time to like show off your true skills because it's on to the next rotation. But yeah, so at the end of my consult week, I had my shelf exam, and the shelf exam was super fair, I felt like, for psychiatry. So I only did UWorld and Anki questions. The UWorld was really reflective of the NBME questions that we had on our shelf exam. So if you're worried about like what resources to use, honestly, if you just use UWorld, and do all those practice questions in the psychiatry section, then you'll definitely be set for the shelf exam. So yeah, I think I did okay on the shelf exam. Hopefully I get honors, but we'll see. Even if I get high pass, I'll gladly accept that. And psychiatry, especially child psychiatry, it's the one I enjoyed the most, but also the one I felt the most frustrated with. But I'm keeping it in the back of my mind, if aerospace medicine doesn't happen to work out, this will be in the back of my mind as a career I might actually consider, because it feels like the lifestyle and the hours are very good. It is, still a little bit demanding, like emotionally and mentally. But in terms of like the total hours worked, I don't think it's as demanding as like internal, and definitely not as surgery. So I think it's definitely a good lifestyle specialty. And I think there's always going to be a career for psychiatrists. I think we're only going to see more and more sort of psychiatric diagnoses and people with psychiatric illnesses as time goes on and as people continuously get older. So I feel like there's always going to be a need for psychiatrists. I don't feel like the job market is going to be oversaturated. In fact, I think we need more psychiatrists than are currently available. At least that's kind of the sense that I got from kind of the limited amount of attendings and residents that were available in our units. But yeah, that's pretty much my overall experience with psychiatry. I enjoyed it a lot. I'll rate it an 8.5 out of 10 if I had to rate this clinical rotation. So my next clinical rotation is internal medicine, which is a beast of a rotation. It's 8 weeks long. So it's going to be the longest rotation that I've done yet. I'm super pumped for it because, internal medicine is like all of medicine, basically. The specific subspecialties that I'm doing, so I have general medicine for 4 weeks, and then I have like leukemia and cardiovascular ICU or something like that. But, I'll talk about that in later videos and at the end of my internal medicine rotation. But I hope you enjoyed this video. Feel free to leave any questions below about psychiatry, or if you're interested in it or have any questions that I didn't address about what psychiatry is like in the hospital. We had kind of actually limited exposure to the outpatient psychiatry setting. It was mostly the inpatient setting. And from what I can tell, like the inpatient setting is definitely a lot more acute and kind of like really high maintenance psychiatric issues. But in the outpatient setting, it's mostly just kind of managing long-term patients, managing depressive medications or schizophrenic medications. It's not really too acute in the outpatient setting. That's kind of the experience that I feel like I had. But yeah, hope you enjoyed this video. Stay strong and healthy, everyone. I hope, whatever you're doing, that you continue working hard in your studies. If you're applying to medical school and, you send in your primaries and you're going to have your secondaries soon, I wish you the best of luck. Feel free to reach out at my email that I have below if you have any questions about medical school or life in general. So stay strong and healthy, everyone. And as always, date bayo.